I'm a medical oncologist. My name is Lajos Pusztai. I'm a professor of medicine here. I joined Yale about 12 years ago from MD Anderson Cancer Center, and I lead the Cancer Center Genetics and Genomics program. It's a large research program for the faculty to, apply genetic technologies to sort of move the field forward. So I assume that you are all kind of familiar with HER2 and HER2 positive disease. So HER2 is basically a cell surface protein that sits on the surface of cells, and it's a receptor. It is a lovely acronym of HER2, but it's really an abbreviation for human epidermal growth factor receptor, because it binds molecules which are in the environment of cancer cells, growth factors, epidermal growth factors, and they make the cells grow. So the major breakthrough about 20 years ago was the discovery or the development of antibodies that could actually interfere with the signaling of this receptor, and that become Herceptin. That those of you who are patients probably all have been exposed to at one point or another. So Herceptin was one of the first targeted therapies for breast cancer, and it's become really, really remarkably effective in making every other therapy that we combined it with more effective. And since that initial discovery about 20 years ago, we have now a whole slew of different therapies. And I'm not sure what your perception is about the disease itself, but it used to be considered one of the worst actors among breast cancers, and that's changed. So now actually with HER2 positive disease, many patients in the early stage setting are cured, but not everybody. So we are working on it, trying to maximize this chance of cure. And also in the metastatic setting, and I hope this is the experience of you as well, that people live longer and longer and with better quality. So the most recent development in that field that you probably have heard about was the development of a drug called TDXD, or HER2, which is basically Herceptin with a chemotherapy drug attached to it. We had an earlier version of it, which was called Godzilla, or TDM1, which is also Herceptin, but with another chemotherapy attached to it. So these antibody drug conjugates, you could think of them as basically targeted chemotherapy. They're a little bit less side effect than the naked chemotherapy drug would do, and it's a little higher efficacy because it targets and brings the chemotherapy agents directly into the cancer. And this most recent iteration of this idea, the HER2, there's a chemotherapy drug that we otherwise wouldn't be able to use. It's a very effective treatment, but it's too toxic if you just do it as a naked sort of IV infusion. And it's also become remarkable because it started to show efficacy, pretty remarkable high efficacy rates in patients who were considered not to be HER2 positive in the past. So the HER2 positive disease is really cancer. We used to define it as cancer which have more than 2 of the normal copies of HER2. It's an amplified, the gene is amplified, so they actually have multiple copies rather than just 2, leading to a very high expression level of this protein. This new drug, this Godzilla, the HER2 drug, actually works on cancer cells which have less of this HER2 protein on their surface. So they traditionally were considered HER2 negative, but we now call them HER2 low. And there is a study which actually explores this drug even in HER2 negative patients that are negative by the traditional routine clinical immunohistochemistry. So this idea of HER2 positive disease in the context of this new drug is really expanding. And then many more patients are eligible for this drug now than historically were considered HER2 positive. So this is kind of the introduction that I thought I'd just bring to your attention about this new therapy. But I really love to hear your thoughts or have this more like a conversation or discussion around this disease. So please don't be shy and ask questions if you have any questions in mind, or just tell me what topic you would like to hear about.
I have a question. I don't know how to do this.
Actually, I think they are recording this and they asked us to push a button. So I think it's supposed to be 3. Maybe hear you. Yes, I hear you.
My question is a kind of a concern that I'm hearing about. I'm on HER2, and I asked my doctor if I could start on a lower dose, only because I'm in the support group.
Yes.
Before I started it, that was like what I was getting from most of the people that were in my support group, and so she did start me at a lower dose. And is that like a common thing to start patients on a lower dose and then maybe make it higher so they can tolerate it? Because the first 2 times I got it, I was knocked
Yeah.
out cold. It was so
Right.
bad. Now it's great, I'm fine, my body's used to it, I'm not having a hard time.
Yeah.
at all. But I'm on 80. Yeah, she started me at 80. So if my body's getting used to it now, if she bumped it back up to 100, like the regular dose,
Yeah.
you know,
So,
the common thing.
this is a common thing. And the sort of journey through metastatic breast cancer is really highly individualized. And you probably all have a slightly different experience and sequence of the therapies that you get. And that's because really we can't predict who will experience what side effects and how severe the side effects will be. So very commonly, we start out with the dose that was used in a clinical trial. And you know that the phase 3 clinical trials, which lead to the approval of drugs, are preceded by phase 2 trials. And those are preceded by phase 1 studies that my colleague, Dr. Adriana Khan, is going to talk about at 10:30. So the purpose of the phase 1 and the phase 2 trials is to actually identify the amount of drugs, the dose, that most people do well. But it's really most people, right? So this is the drug concentration and amount that goes into the large randomized phase 3 study, which compares it with all the drugs like the TDM1 or Kadzilla. So typically we start out with that dose. That's the FDA approved dose that showed the efficacy and the described side effects that was used in the phase 3 trial. But we also know that some patients actually will have side effects and some will have severe side effects. Sometimes physicians have a hunch, a gut feeling, that who might actually do worse than the average patient in a clinical trial. So patients who receive many prior chemotherapies tend to have a little bit of a compromise or some difficulty tolerating more treatments in terms of their bone marrow because it's just been hit so many times. And oftentimes physicians start with a lower dose, and that's perfectly appropriate, and you try to build it up. Now, with the lower dose, the question that always lingers in the mind, I think, of you and also your physician maybe, is that will it be as effective because you get a little less drug? And oftentimes, quite surprisingly, studies that looked at either in real life, like just collecting data from medical records across the country and across institutions, or even in prospective studies, it turns out that reducing the dose oftentimes doesn't impact the efficacy of the drug. But just because this is how the drug was approved, we usually start with that particular dose. But it's not unreasonable, and we do this oftentimes, especially if you have a sense that a person may have difficulty tolerating the regular dose at the lower dose, and then you can increase it. And if it agrees with you, then you continue with it. And if it doesn't, you just go back and continue at the lower dose. Yeah.
And it's actually working very well. Knocked out.
No, I'm really glad to hear that. Yes. Yeah. Yeah. So there are many new drugs in that space. And, you probably noticed that all of these phase 1, phase 2 trials are actually introduced or started in metastatic disease. And it's a good idea to discuss the availability of clinical trials because some of the clinical trial drugs that are currently investigational will become the standard of care in the future. So HER2 was an experimental drug up until like a year ago. And there are many new ADCs which kind of follow this paradigm that what if we stick another chemotherapy drug to Herceptin? I mean, to be honest with you, for us, it was a surprise that HER2 worked so well in patients who progressed on the exact same antibody with a different drug attached to it, the Kadzilla or TDM1, and it worked amazingly well. So there are now other sort of derivatives of this same idea. Herceptin conjugated with yet another antibody, yet another drug, cargo.
So if I do my run with HER2 and then it starts to fail, could I switch to one of those other ones, or
So,
are they too similar to HER2?
Conceptually, of course you could, but you need to ask your physician and I think it's a good idea always to ask your physician, is there a clinical trial for me that I would be eligible for and you think could work? So whether you particularly or personally will be eligible for a study, it really depends on when you need that switch and what eligibility criteria the trial has. So, clinical trials open and close. and many open for a year or 2 years, and then we finish it. And then depending on the results, it gets approved or it moves to another study to get more information about a drug. But also, what is particularly difficult with clinical trials is that every clinical trial has about 20 different eligibility criteria. So you only could have one prior treatment. Your cancer have to be measurable on a CAT scan, whether you can't have this or that laboratory abnormality, and many other things that sort of narrow down ultimately the number of patients who could participate in it, because you need to meet this eligibility criteria as well. Yeah.
When I was first diagnosed, all my HER2 status was very inconclusive. And then when one of my treatments failed, we did a whole lot of additional testing. At that point, it was determined I was HER2 low. So that shift, will that, like, do you know anything about progression of HER2 over time? Like, what does that mean, that it was something that shifted to something else? Should I expect more shift? What's the change over time?
So that's actually really, we see this very regularly, that your estrogen receptor number changes or the HER2 status changes, particularly this HER2 immunohistochemistry result, which is like an assay to measure the amount of HER2 protein on the cell surface. And it's a relatively crude assay, and it's reported out as HER2 0, there's no signal or no binding of this immunohistochemistry antibody, which is a different antibody. It's not the same one that's used in the clinic as a therapy. So 0 is no signal whatsoever. 1 is a little bit of signal. 2 is, and the 0s and 1s were considered HER2 negative. The 2s get a sort of a confirmatory test, a FISH assay at Yale at least. And if this FISH, which measures the amplification of the gene, positive, then we call you HER2 positive. If it doesn't show amplification, that even with this HER2 2+ immunohistochemistry result, you historically were considered negative. And then there are the HER2 3+. So these numbers, the 0, 1, 2, 1+, 2+, 3+, based on the immunohistochemistry assay, changes. And we actually think that it's due to 2 reasons. One is a technical error. So unfortunately, all of these assays and results have a variation, a technical variation. So from going to 0 to 1+, actually, it's a little bit in the eye of the pathologist. The same from 1+ to 2+. From going from 0 to 3+ would be very unusual or unlikely to be a technical error. But these little switches from one category to immediately above or immediately below can just be a technical variation. And but there is also real change in the biology of the disease. So you can imagine this, that you treat the cancer cells with treatment, they evolve. So they have to survive somehow the treatment and start to grow again. So they do change. And so both of these things are happening. And what actually happens in a particular instance, we can only really figure this out with great precision, with a lot of additional sort of technologies applied to the cancer tissue. But I think the most important practical thing is that as long as you have a little bit of staining on the immunohistochemistry, now we consider you HER2 eligible for the HER2 or HER2 low. So pathologists, because of this, actually started to change the way they report things. So now they understand is that reporting out 0 would deny, under the current system, patients from the chance to get the HER2. So we see fewer and fewer 0s, and they start to report them out as 1+. Some of this is technical artifacts, but it gives the chance to the patient to try the drug. And actually, AstraZeneca and Daiichi, who developed this drug, have a clinical trial for the completely 0 negative patients, because it's actually possible that even the completely 0 patients do respond, because 0 is really just, like everything else, it's a threshold. So if you think about this in terms of physics or chemistry, if you have 1,000 molecules on the surface, then immunohistochemistry wouldn't pick this up. It's just not enough signal. But maybe 1,000 on the surface of the cells is enough for this drug to work. And that's how the 0s could actually benefit. And we see this in the context of other antibody drug conjugates as well, that actually their target, the protein that they target very specifically, the amount of it, as far as we can tell with these relatively crude immunohistochemistry assays, doesn't seem to actually predict who will benefit from the drug and who won't, because the assay is less sensitive than the actual treatment. So what you experience, the bottom line is actually we do see that fairly frequently. In the past, we didn't attribute much to it, but now we do take this into account very seriously because it renders patients eligible for this pretty effective new drug. But again, that's not effective in everybody, and that's why research never stops.
First, thank you for all you do to help advance the understanding.
You know, I just do the talking. You do the difficult part.
Young daughter's diagnosed with HER2-positive breast cancer, and I'd love to hear. It sounds so singularly focused, and of course, in this age of personalized medicine, where we know there are multi-variables that can predict the disease, is anyone studying? You know, it can't be just the number of amount of HER2 responder, the scale that you described. What else is giving you the information you need to help treat this type?
Yeah. So, you know, what we use today in decision making, that's not perfect, but what we use today is the estrogen receptor and the amount or the percent positivity, which gives an idea about how sensitive the cancer will be to endocrine therapies. And the endocrine therapy sensitivity remains a valid sort of therapeutic option for estrogen positive, HER2 positive patients. And we just use a different combination of drugs. And in some ways, having that subtype of HER2 positive disease is a good thing because it opens up additional therapeutic options, the endocrine drugs, in addition to the chemotherapies and ADCs. So we use the estrogen receptor level, the progesterone receptor level, because it also gives a little bit of an idea, a hunch that how well the endocrine therapies will work. Patients who are positive for both of these hormone receptors, these female hormone receptors, tend to respond to endocrine therapy better and have a longer time before their cancer sort of escapes from endocrine or becomes endocrine resistant. So we use the HER2, and the expression level actually does matter because, you know, the higher this level, the more likely that patients actually respond. But even at the low level, there is a chance to respond. So we try it. And currently, these are really, and we look for a sort of additional rare abnormalities that have some indication about whether a person will benefit from additional things like a protein, a PI3 kinase inhibitor, which is an enzyme that also promotes cell growth, but it's really not that frequently mutated in patients, or additional things like a BRCA mutation in the cancer, against which we again have drugs. And a few of these other molecular abnormalities that are targetable. So most patients have a molecular profiling assay that reports out these things, these rarer sort of therapeutic options based on the molecular abnormality. But, you know, there's a lot of research what else we could do to really refine this, who is more likely to respond, who needs additional therapies to respond, and to predict how people do. So the current assays are not perfect, but these are the ones that we use currently. The estrogen, progesterone, the HER2, and these sort of molecular profiling or tumor profiling. Some of you may have had it, so the Foundation Medicine assay or the Tempus molecular profiling assay. There are many companies in that space. I think Yale has a special sort of arrangement to do this through Foundation Medicine, but we also work with other companies who provide similar sort of molecular target assessment.
Yeah. Helpful. Not surprising, but it also affects, like when you would introduce, say, the hormone therapy, HER2 positive, like how that decision is made based on, it's not just the molecular profile. My understanding is that hormone therapy is coming in earlier than it used to.
Yeah, so, you know, so journeying through metastatic disease is a little bit like journeying through life. You know, it's the decisions that you make with you and your physician, with your family, sequentially. and everybody's journey is a little bit different. The guiding principle is basically that we use treatments one after the other, hoping that each of them will control the cancer for a long time or a variable amount of time, and they add up to a good many years. And the other principle that we oftentimes use is that we try to favor drugs which have the least effect on someone's quality of life. And endocrine therapies tend to be easier to do, have fewer side effects than chemotherapies. But we always combine these in HER2 positive disease with some sort of a HER2 targeted therapy, because the HER2 targeted therapies make the endocrine therapy better, the chemotherapy better in terms of being more effective. But you are right. So we usually started with the endocrine therapies in a HER2 targeted agent like Herceptin or pertuzumab or both, because it's a little bit easier to do that. And it has a good chance to work and has fewer side effects than starting out with chemotherapy. But usually chemotherapy at one point also will become necessary because the cancer over time just simply becomes resistant or immune to the endocrine manipulations. Also, sometimes over time, actually cancers regain sensitivity. So sometimes we go back to drugs that someone might have received 3, 4, 5 years before. And remarkably, the cancer regains the sensitivity. But this likelihood that something that you had before would work again is proportional to the time between the retreatment, the original and the retreatment. So the longer time passes, the more the cells kind of regain sensitivity. Yeah. So
one question to answer that about being able to go back.
Yeah.
The therapy that you were on before.
We sometimes do that. And again, the likelihood that you would benefit from it is really depends on how long ago you received this previous treatment. And the longer time passes, the more likely that it will work again. Other thing, maybe I just bring up with you because you might find it. Yes.
What are the effects of tamoxifen?
Phesgo. So the Phesgo is a combination of the Herceptin and the pertuzumab as an injection. To be honest with you, Genentech invented that to keep their patent. So it's just as good as the IV form, but the IV forms of Herceptin Perjeta require you to come to the clinic, get the infusions, and it's not making that much money for Genentech. So they came up with the injection form, which I think is some ways maybe easier for some people, but it makes the tamoxifen or the hormonal therapy more effective. So that's why we do both together. So large randomized trials show that, doing endocrine therapy of any kind, tamoxifen or an aromatase inhibitor, have higher response rates, and the response lasts longer if you also use the Phesgo along with it, or the IV form of it. Yeah, so that's really the right thing to do. That's the most effective treatment. The Phesgo, it either has no side effects or you need to watch your heart, because for reasons like the heart has a very low level of HER2 expression that you can't pick up with immunohistochemistry and things like that. But despite of this, a small minority of patients, maybe 3-4%, will end up with having a weakened heart. So we usually do, all these HER2 targeted therapies every 3-4 months. You get an echocardiogram to follow your cardiac function. So that's the side effect from the Phesgo. And the tamoxifen is an anti-estrogen. And it actually is a really interesting drug because it works as an anti-estrogen in some organs, like the breast cancer or the brain. But it works in other organs as estrogen itself. And that's why it increases a little bit the risk of uterine cancer. But it strengthens your bones because in the bones, it also behaves like estrogen. But it causes hot flashes. And that's because it's an anti-estrogen in the brain. And of course, it's an anti-estrogen in the cancer. That's how it shrinks it. Yeah. So the XGBA is good for the bones, right? So that's a bone strengthening medication. And you could do that. And we always do this if someone has bone metastasis. You could think about it as strengthening your bone around the cancer to prevent fractions and things like that.
Brain barrier, you said it goes to the brain of just what all that has.
Yeah. So this is actually one of the really important challenges that we didn't really have such a success to solve. For example, so we noticed that for some reason the brain is a sanctuary site. For the traditional chemotherapies and HER2 therapies have been a real hard time to get into the brain. So oftentimes patients, for example, in the early stage setting where we have a complete eradication of the cancer from the breast, from the lymph nodes, because you get all these treatments upfront at the time of your diagnosis before surgery. If you have this complete response for the early stage, let's say stage 3 disease, most of these patients do really, really well. But the minority who doesn't do well have a recurrence oftentimes in the brain because the micrometastatic disease was eradicated everywhere except in the brain, so it over time grew back. So we had a hard time to find good treatments that work on HER2 positive brain metastasis, but not the HER2. So that have real proven efficacy. And one of them is a combination of 3 drugs, the Herceptin tucatinib, which is a small molecule that inhibits the activity of HER2. The Herceptin is an antibody that binds to it, and we don't quite exactly know what it does, but it blocks the effect, but also probably has some immune effect as well, bringing in immune cells. So if you combine the Herceptin with tucatinib, which just blocks the kinase activity, blocks basically the signaling of the HER2, and you throw in a chemotherapy drug called capecitabine, this triplet actually works quite well in the brain. So unfortunately, it doesn't cure patients, but it controls the disease for a variable length of time. So that's one treatment that works in the brain, this combination of Herceptin, tucatinib, and capecitabine. And the other one that's now we see that the HER2 drug also actually penetrates and works in the brain as well. So there are specific studies with HER2 for brain metastasis, but for the general studies that led to the approval of HER2, we also saw that patients who had brain mets, that actually it's shrunk oftentimes. So currently the 2 best options are these HER2 drug or the triplet combination. But that's probably one of the most difficult sort of locations to treat. And of course, there are radiation therapy that we use. Yeah. So I just wanted to tell you one thing before we probably will need to kind of go to a breakout session, the break, and the next sessions on the phase 1 studies starts at 10:30. But there are 2 kinds of breast metastatic disease, and I don't know what your experiences are, but historically the most common type of metastatic cancer was a recurrence of a breast cancer after an initial diagnosis with a stage 1, 2, or 3 cancer that you may have received treatment with the hope of curing you many years ago, and then the cancer recurs. So that's called a metastatic recurrence. The other type is, we call it de novo, or newly diagnosed HER2 positive disease, where at the time of the diagnosis, patients have not only cancer in the breast or maybe in a couple of lymph nodes, but also in distant organ sites. And these 2 are very different, both biologically and conceptually. The major difference is obviously the prior treatment. So when cancer comes back, despite initial therapies, I mean, we really, really have a very hard time, if ever, being able to cure somebody. And that sort of makes sense, right? Because the cancer survive all these good treatments up front. So it's kind of become resistant to treatments that we had. But the de novo or newly diagnosed metastatic patients who didn't receive any therapy and from the get-go have mets, they might actually be able to be cured with an aggressive treatment where we try to remove the cancer from the breast, the lymph nodes, radiate or eliminate the spots that are in the liver or lung or bone, and use all the same sort of combination regimens that we use pretty effectively now to improve cure rates in the stage 3 or sort of locally advanced setting. So this is a really interesting sort of idea that we are exploring now in clinical trials. And I'm personally really excited about that study. So there's one study that's opening up through an academic consortia, and we are working on actually launching a larger trial throughout the country through a cooperative group, this SWOG Clinical Trial Network. And hopefully this will become available for patients with newly diagnosed disease. So it's probably one be relevant for you, but I just wanted to tell you that we're trying to really move the needle more towards this thing that could be possibly really cure patients with a more sort of aggressive treatment strategy, not just getting a better drug, but applying a strategy. Yeah. So there's a lot of really interesting things in basic science that we hopefully will eventually translate into advances in clinic as well. Like we, for example, learned that metastatic lesions give rise to metastasis. So there is a particular type of or subset among metastatic cancers that we call oligometastatic disease, when you only have one or two sites that are visible on a CAT scan. And there's a bit of a controversy whether it's worth removing those sites or radiating them, killing them off with a sort of a very focused radiation of the bone or lung or liver so that you have no visible disease. And probably I believe that there may be benefit from this because we know that metastatic lesions give rise to metastasis. So we can map out how these various metastatic nodules or lesions relate to each other. And we oftentimes see when we do this that basically one met originated from an earlier metastasis somewhere else in the body. So eliminating or killing that reduces a little bit the risk that sort of live metastatic lesions would eventually spread and disseminate to other sites. Yeah. So maybe if you have one more question, but if you don't, then we probably need to break for the break. Thank you.